Bismillah ar-Rahman ar-Rahim, Bismillah wa-salatu wa-salamu ala Rasulullah. And welcome, Dr. Mohsen. Thank you for being here with us, and thank you for joining us, and thank you all for joining us early in the morning. So, Bismillah ar-Rahman. So I'm going to talk a bit about, in the next 15 minutes or so, a bit of our experience and a few thoughts about AML and how we treat it. Now, we know that AML is a remarkably heterogeneous disease. It's clinically heterogeneous, genetically, epigenetically, and phenotypically. They behave differently, and we don't have the outcomes yet that we would like to see. So I'm just going to talk a bit about our population and demographics, some of our survival studies, some studies that we've done looking at the molecular characterization and outcomes. So we know that in AML, in almost all patients, you have multiple malignant clones, and each of them is characterized by unique configuration of genetic and epigenetic abnormalities, and hence we have differences in outcomes. And there are a number of whys in AML as to, why does AML cause, failure of normal hematopoiesis? Why does it get bone marrow failure? Why are presentations so varied? And why do apparently the same AMLs behave differently? And one of the other questions is, why do AML patients relapse, and how we can address that? And we know this is a great work from Eli Papa Emmanuel from 2016 from the Wellcome Trust around Cambridge that they published in the New England Journal of Medicine that informed us of the mutational burden in AML and that long tail of mutations. And this was in the news saying how AML is a heterogeneous disease. There's 11 different subtypes. So obviously the field was evolving, but maybe survival wasn't catching up as it should be. So, so that's the background. So how are we in terms of AML? It's great knowing what happens to everybody else, but we're interested in what happens with our patients. So we have an AML registry in which we have 1,347 patients that span 40 years with a median age of 35, right, which is not the AML that you see in the West. The median age of AML in the West is 66, 67 years. That and our AML population is remarkably younger. And this is the overall survival of patients in a relevant period. So between 2011 to 2013, so the entire database is 1,300 patients. This is a survival of around 500 odd patients treated between 2011 and 2013. So as you can see, the median survival for these patients is 40 months, and the 5-year survival is 48. Now for that median age, it's not quite what you would expect. So why is that? We know that there is data, and this is just one study that was recently published in Blood Advances. There is data, there are a number of publications that talk about the ethnic heterogeneity in AML and how patients of different ethnicities have different outcomes, even from the same areas, same regions, even the same institutions. So this was the outcome for from Baylor, and if you can make out over here, so the red curve are the white non-Hispanic patients, and the blue and green curves are for Black and Hispanic patients. And as you can see, let's say for certain subtypes, say the MLL rearranged ones, they do worse, and in even the core binding factor ones, you can see the patients, the Black patients, do worse. That's the blue curve over here, which is the Black patients with core binding factor leukemia. And this is something that we had seen, and I know we've talked about it, and, from Dr. Muharib's work, and we tried to follow it up, and we tended to see the same thing. So we looked at 59 patients first we looked at 216 patients who were treated between 2004 and 2015, and we found that patients with translocation 821 over here had outcomes that were similar to the intermediate risk AML. That's the adverse risk that separated out quite nicely, and that is the core binding, the inversion 16 patients up here. Well, up here. Sorry, I can't quite. Anyway, the top curve is inversion 16, and the green curve is 821, and the red curve is intermediate risk. So they almost overlapped. So that also just reiterated to us that the 821 patients who otherwise you would expect to do better don't do as well. And that was our survival rate 821, and we tried to divide it by post-remission therapy. And people ask, why do you do auto-transplants? Because we found that the relapse is a lot higher in patients who had chemotherapy alone. That's why we used to do autologous transplants for AML with translocation 821. Now we give them Mylotarg. But then we wanted to know a bit more, are there any genetic abnormalities? Is the mutational profile different? And obviously it took a while before NGS myeloid panels became available for all of our patients. So with the help of our outstanding PhD student, Dr. Manar Al-Faham, who's currently in London, we did one sort of preliminary study as a background to her PhD work, which was we looked at all the patients on whom we had mutational data. So we had 393 patients. We reviewed the cytogenetics and molecular for all of them. So we had two cohorts. One cohort had the cytogenetics, but they only had PCR-based results for FLT3, NPM1, SEPA, KIT, and those other mutations, IDH1, 2, WT1, T1, DNMT3, and JAK2, and quantitative PCR for RUNX1. So that was the old cohort. Then we had a cohort in whom we had these mutations, but in addition to that, we had the NGS myeloid panel. And this was interesting. And a bit unexpected. The text is small, but if you recall the Ella Peppa Emmanuel work from the New England Journal, it's NPM1, DNMT3A. Here, oddly, 18% of our patients out of over 100 on whom we had, and just had RUNX1 mutations. A bit unexpected, followed by NRAS, and then TP53 mutations. So there was an enrichment for TP53 mutations in our patients, which was also a bit unusual. Now, if I may, I might go back very quickly to jog your memory to here, okay? So you see FLT3, NPM1, DNMT3, NRAS, and TP53 comes somewhere in the middle over here, over there somewhere. So, okay, around, this isn't really accurate, but anyway, in the middle you have TP53 outside of that red box of the most common diseases, of common mutations. And again, as you saw, we saw RUNX1 also comes around over here. So that's RUNX1 and TP53 is over here, and FLT3 and NPM1 are the most frequent. So you can already see in our patients that yes, does seem to be a slight a signal to say there is a slight difference in the mutational profile. FLT3 ITD, then you have IDH2, ASXL1, and the remainder of the... and then you do have a long tail of mutations that I've put in one bar over there called others. But there is a long tail of mutations. And then we risk stratified all of those according to ELN 2017, and we did survival analysis. Now, what you can see over here, this is cohort A, in whom we didn't have an NGS panel. So obviously, we weren't picking up TP53 mutations here. We weren't picking up RUNX1 mutations here. And the discrimination between adverse and non-adverse seemed less, the ability to discriminate seemed less powerful. On the right, we have cohort B, where we were able to, where we essentially stratified them based on the NGS, because that was the most comprehensive profiling. And as you can see, they separate out nicely, and the curves between the non-adverse and adverse seem to separate out more nicely. However, you have to bear in mind that that's a later cohort, and as you can see by the censoring lines, the follow-up for the patients on the left was longer than the follow-up for the patients on the right. But it did emphasize the need to have comprehensive mutational profiling. And I think in the 2020s, it is impossible to treat AML without full mutational profiling if you want to treat them correctly. So it seemed that the mutation profiling in young SID patients seemed to be slightly different from what we would expect from the published literature. And that's really important, the power of regional and local data. Now, and we had been talking about this for many years. You know, with Dr. Muharrab often used to tell people that our patients are not the same. And we've had different conversations about this. And we used to often have a conversation about this with Our esteemed Professor Mufti, who is an honorary hematologist in Saudi Arabia, and somebody who's very close to us and visits many of us, and we see as so we often used to have this discussion. And then this paper came out a few years ago, the whole genome sequencing in AML from the St. Louis WashU group, where they looked at 263 patients with myeloid malignancies, and they had 175 AML cases, whole genome sequencing. And just before this, we acquired the equipment, the NovaSeq 6000 that enabled us to do whole genome sequencing. And I must be grateful to Professor Sultana Saderi, the previous chairman of the research center, who, along with Prof. Mufti and ourselves, we had a discussion, and it was decided that the first project on which we were going to do whole genome sequencing was going to be in AML. And the agreement was the work was going to be done in Saudi patients. The work will be done in Saudi, so the analysis will be done here, and the preliminary bioinformatics will be done here. But it will be done in collaboration with King's, because we had this outstanding scientist, Dr. Manara Faham, who was going to do the PhD. So that's registered there. So she's doing the work between here and the UK. But the previous work, a lot of it was done by her, and she's done. We didn't think this would be possible. Now, if you look at this, this was 263 myeloid cases, 175 cases of AML, whole genome sequencing, with a depth of 50x. We were able to do whole genome sequencing in 215 cases from our patients. We had a prospective cohort and a retrospective cohort, and as I said, I didn't think it would be possible. I thought it was too ambitious, but alhamdulillah, we were able to get 200 cases whole genome sequenced. We were able to get molecular, with collaboration with the pathology DPLM and CGM, we were able to get DNA. We consented all patients who we could as they came to clinic. So Manara sat with us in clinic and consented patients as they came. We tried to get a germline DNA through buccal swabs and saliva. And for the ones we couldn't, we used Manara's using a bioinformatics pipeline to try to distinguish germline from somatic mutations. So the work was done in the CGM mainly. And so she was able to characterize 106 known and novel germline variants in 75 AML patients. And on the right is a plot for the somatic variants in the cohort, which was quite interesting. And I won't go into the details and take away from what Manara is going to do eventually when she presents this, but I'm just going to highlight a few interesting findings. So the mutation exclusivity and co-occurrence of mutations, so NPM1 and FLT3 we know about, but we saw these concurrent mutations, ETV6 and COX1, ETV6 and CBL, which is obviously one of the mutations that's associated with a germline predisposition to AML, CBL and TET2, and BCOR, and a number of concurrent mutations that seem to be more frequent than one would have expected. And then you have a circus plot of the different kinds of structural variants and co-occurrence of structural variants, and this is different from the New England Journal paper of Patel et al. And the Papa Emmanuel study. Again, because we were doing whole genome sequencing, we were able to identify copy number variants, and we were able to see the difference in outcomes based on copy number variants. So this is the power of whole genome sequencing that you wouldn't be able to get by the NGS panels. Now, what was most interesting was this. Again, I'm not going to go into all the detail, and inshallah one day, Dr. Manara, I think she presented in the Saudi SSBD. But some of the mutations where we thought there would be a major impact on outcome, it didn't pan out in these patients. So FLT3, ITD, even though there's slight differences. Yes, some of these patients got FLT3 inhibitors. But even if you look at, say, RONX1, we thought we'd see a greater separation of curves. We did see IDH2, patients with IDH2 mutations having a trend towards a better outcome. But what was interesting is seeing the patients where mutations did seem to make an impact. So the cohesin complex mutations, STAG2, TP53, obviously, CHEK2, JAK2, KMT2A, and BCOR-L1. These had a significant difference in terms of outcomes. So So the conclusions were, it's important to have databases, and it's important to have local and regional databases. It's important for us to understand our population, and we shouldn't always assume that our populations and our patients are like the Western population, and that's being understood more and more, and that's why in clinical trials now they want enrollment of patients from different ethnicities, different regions, and we should take advantage of that that drive and that change in attitude to enroll, again, more patients from our region enrolled into trials. Databases are very important, and I would say databases and having up-to-date databases and mining that data is probably more important than investing in getting 2 or 3 patients on a clinical trial. I know that's sort of a contradiction of what I just said, but the most important thing is understanding our patients, understanding our outcomes, and understanding our risk factors. So we need local data, we need local research, and we need to collaborate on that. Not all patients are the same, not all AML is the same, and the mutation profile in a young Saudi cohort appears to be different from that in the West. Very briefly, in the next couple of minutes, so basically this is how we kind of treat AML. It's always evolving, but generally, the aim is, as we can see, we need to improve our outcomes, and we need to implement the best standards of care, the best practices that are evidence-based to try to improve those outcomes. We can't improve our outcomes if we don't risk stratify our patients properly, if we don't have a mutational profile, if we don't give targeted therapies when the evidence suggests or the recommendations that they should get it. So for core binding factor patients and for other favorable risks, we make sure that everybody gets Mylotarg, and we've done that for the last at least 3 years to ensure and incorporate MRD. Again, we're able to incorporate MRD with RUNX1T1 transcripts, but hopefully we'll have it for NPM1 and CBF beta MYH11, inshallah. For FLT3, we have to have an upfront FLT3 inhibitor. And for adverse risk, obviously intermediate risk and adverse risk patients eventually will go to a transplant, but we need to optimize their upfront therapy. I think patients, especially young patients, are better off with high-dose RSC containing regimens, but the challenge is sometimes trying to incorporate the third agent, like whether it's a FLT3 inhibitor or Mylotarg, because the license is with 3+7. So that is why we are reluctantly still giving 3+7, but hopefully, if we're able to, with whole genome sequencing, and inshallah we hope to have rapid whole genome sequencing up front, then we will be able to accurately stratify our patients, and then we hope incorporating other algorithms, incorporating AI with the large data set that we have, that we will be able to test this cohort through an AI algorithm to see if we can accurately predict outcomes in our patients. And with that, I'll end. Thank you very much. I think we have to thank Dr. Manar Al-Faham, outstanding PhD student, inshallah, who's done amazing work for our patients. We're all very proud of her. And I think great thanks go to Dr. Sultan Saderi for supporting and collaborating with us, Professor Mufti, and then all the colleagues, all our fellows and all our assistants, Dr. Ahmed Al-Ataybi, everybody who has helped to put all this data together. And thank you very much.